And I'd like to introduce Dr. Anne-Marie Rosland. She's the core investigator at the VA Pittsburgh Center for Health Equity Research and Promotion. She's also the director of High Risk Network and Analytic Core at the VA Office of Primary Care Analytic Team. She is an associate professor of internal medicine with tenure at the University of Pittsburgh and the director of Pitt Caring for Complex Chronic Conditions Research Center. And then we also have Dr. Thorpe with us. He's the associate professor in the Division of Pharmaceutical Outcomes and Policy, healthcare scientist in the Department of Veteran Affairs, and the director of analytics and research in the VA's National Center for End-of-Life Care. We also have Dr. Franya Hutchins with us. She's a postdoctoral fellow at the VA Pittsburgh Center for Health Equity Research and Promotion. And can we turn things over to you, Anne-Marie, to get started? Dr. Rosland, you're currently muted. Okay.
Hello, can you hear me?
Yes, we can. Thank you.
Okay, great. Thanks, Maria. As you heard today, we're presenting work on segmenting the high-risk complex patient population, both methods and applications to VA care. And this work that we're presenting was conducted as part of a high-risk patient care analytic group that's part of the VA Office of Primary Care Analytics team, which is a multi-site group of VA investigators dedicated to using insights from analytics to inform and improve primary care in the VA. And all three of us are investigators at the VA Pittsburgh CHIRP coin, as you heard. The work we're showing you today has been supported by multiple groups across the VA, as well as staff and veteran advisors, and our team and collaborators, and the National Investigator Network that collaborates on projects to address care for high-risk patients. So lots of folks involved, as you can see here. So today during the cyber seminar, we are going to talk about why you might want to use healthcare system data to segment patient populations in a healthcare system like the VA, and how you would go about doing that. When we talk about how we're going to take a programmatic or a clinical leader perspective, the perspective is somebody who might be working with a data analyst or a statistician to do these models. Then we'll talk about the specific situation of high-risk complex patients in primary care and why this is really a perfect scenario for using population segmentation and how we have approached this in our team. And then finally, we'll talk about ongoing projects that are trying to apply population segmentation results to tools that can be used in patient care. And we have a poll.
And the poll is currently open. What is your primary role in the VA? Is it clinical/patient care, operations or administrative, informatics or programming, research, student trainee, or other? Please go ahead and answer the poll questions, and please don't forget to click submit. The polls are coming in slowly, and we have a good percentage of people responding. And it's slowed down, so I'm going to go ahead and close that poll. And I'm going to go ahead and share the results. And what we see is 22% of the audience selected clinical/patient care, 12% selected operations or administrative, 2% selected informatics programming, 44% selected research, 2% selected student trainee, and 5% other. Okay, back to you, Dr. Rosland.
Perfect. This is really helpful. We definitely have a mixture of people, but a lot of researchers, both people who might produce these models and then people in clinical and operations that might use them. So that's the perfect segue to introduce Josh Thorpe, who is the statistical mastermind behind our work.
Thanks, Anne-Marie. Okay, so the question that we begin with is sort of why would we segment patient populations? Like, what's the point of doing this Why do we even need to be learning about these sort of complex methods? And so what I'm going to talk about a little bit in my section is sort of the reasons. So, oh,
Sorry about that.
no problem. The reasons why we might care about patient segmentation. I also want to just kind of keyword it for those of you who are familiar. So patient segmentation, it also is sometimes known as sort of mixture modeling. You'll hear it as cluster analysis. You might hear it as latent class analysis. The idea is, and I want the audience to sort of keep it in their head, that we are taking an entire veteran population of high-risk patients, but then we're going to try to divide them up into groups. So that's the patient segmentation piece. Okay, so why would we do this? Well, it's this balancing the population. We want to provide all our veterans, the ideal quality of care. We want to be efficient. We want to be effective. We want to be cost effective. And that's the goal of sort of any integrated healthcare system, including the VA. But the ultimate goal is to coordinate care around the needs of a specific patient. So I think of this as there's this tension between providing personalized care, but also for a healthcare system like the VA, how do I do that? I have millions and millions of patients, and how do I do that sort of efficiently? And so one idea, so that's the system challenge, is to construct an efficient and sustainable healthcare system to care for entire patient populations while we're in the era of tailoring or sort of personalized medicine to the care of individual veterans. So one way to think about it is, can you build a system that maybe has to balance between these two tensions? So build a system that balances population care and individual level care. So one solution is to segment populations or our veterans into small sets of groups that share similar healthcare needs. So we're getting people into groups, but this group is a group we can care for while meeting their own individual veteran needs. So it's sort of this balance between every single veteran gets their own care plan to population-wide, we're just going to do the same thing for everybody. So that's our sort of main reason for thinking about segmenting patients. And the idea that we're operating from is actually kind of straightforward. And here's just an example, a toy example of, you've got three types of cubes or figures, different colors, and is there a way that we can cluster them so that oranges and oranges and green and green and red and red, these could be patient populations come together. But the idea is that these patient subgroups all encountered in a similar place in the healthcare system, but have qualitatively different healthcare needs. So we want to identify the groups that are different from one another in how they and potentially what their healthcare needs might be. So these patients don't need a one-size-fits-all treatment plan for the entire population. So in some cases, we may be able to guess the best ways to group these patients, and segmentation allows us, or it really allows the data to tell us what patients might and naturally group together in a clinically meaningful way. And so I know in the VA, those of you who do either both clinical care and research, you're familiar with things like CAN scores. These are risk prediction scores for our veterans. So we have scores that exist that predict risk of severity of certain outcomes. And on the left, you can kind of think of like, these are tiers of outcomes that range from maybe sort of more mild to more severe on the top. And so the CAN score, for example, predicts risk of hospitalization, or scores that predict who might be high cost. But the goal of segmentation on the right is a little different. In segmentation, patients may have similar quantitative levels of risk, but qualitatively different profiles. So they might require different types of care. So it might look like you might have two patients who they have a risk score arbitrarily of, let's say, 70, but how they got to 70 is very different from a clinical perspective. So next we want to talk about how, so there are many ways you could think about dividing up your populations and putting like to like together. The one that, and so I want to sort of put this in a context, next slide. so in the context of what we're doing, just briefly taking a step back. So for those who are familiar, and we're all becoming more familiar with things like big data, machine learning, this is a slide that kind of divides up the types of things that you might want to do. I'm going to focus on the left side. So if you start at the top and you see machine learning, I'm going to talk about what they call unsupervised machine learning. And that just means we don't have an outcome in mind. We just want to group likes. It's kind of you can think of it as pattern discovery. And so on the flip side of that, that others are really familiar, if you're into the sort of machine learning, is the predictive analytics. Now on the right side, and I'll show you an example of this. These are cases where you really have an outcome of interest. You want to predict 30-day readmissions. You have something specific in mind, and that specific outcome is going to help you, is going to guide how you classify patients. But we're on the left side where we're focusing on, like, I don't have an outcome of interest. I just want to classify patients that have similar co-occurring comorbid conditions. Next. But just to sort of drive that point home, and we obviously are not going to go through the details of this, but to give you an idea, this is what supervised machine learning is. If we were on the right side, if you look at the top of this, is a classic case of a classification of regression tree, or CART, and we were trying to predict hospitalization. So the whole model is going to be supervised by people who are hospitalized versus they're not. There's somebody who has an outcome, and you might start at the very top here with poor health. So that poor health is a variable, and it's going to be used to sort of split things based on what are the splits that are related to hospitalization. So poor health, maybe age, maybe stroke, and that's all fine. That gives you a very specific patient classification profile that is designed specifically for an outcome of interest. But again, we're sort of more interested in segmenting populations, not necessarily by specific outcomes. The other thing that in our group we're really thinking a lot about, and is that you might identify clusters of patients or clusters of veterans who share similar types of comorbidities. And that is a classic latent class or segmentation problem. But there's also sort of you can think about it as a more nuanced way of considering risk. So yeah, there might be classes that have co-occurring comorbidities, but what about within a class? Are there, within a class of a class that or a segment that we find, are there people who are more ill or less ill? And what this slide sort of demonstrates is that with some more advanced, we're going to call them hybrid methods, you can actually not only identify which groups co-occur and how to put veterans into certain groups, but you might be able to rank order along a continuum. And we talk about that in terms of mixture item response theory. It's not the focus of this particular talk, but it's really important because it allows you can allow individuals to be placed in a class, which means a group of people who share similar comorbidities, but you might also be able to, within a panel of patients, rank them in terms of sort of severity or illness. I like this next one, although it looks a little crazy, but this is just an example of a cluster analysis of comorbidity. So on the left here, and again, there's no outcomes in mind. These are just how conditions co-occur. At the center on the left is diabetes, and then you can just look and see in this cluster-based approach or segmentation approach, which are the types of comorbidities or things that would go along with diabetes. And the size of the circles that are extended to it are the ones that are more prevalent. So with diabetes, it might be stroke, it might be glaucoma, you might be dealing with arthritis. And then similarly on the right, you might have hypertension as kind of the center of, lots of patients have hypertension, but you might have groups that go along with that have asthma, or they might have just another range of types of conditions. So you might have a primary diagnosis that you're focused on, but the truth is you would be thinking about, well, what else goes along with this particular diagnosis that might be common, and should I probe the patient about whether or not that's something that we need to talk about. Slide 14. So our group, led by Anne-Marie, so we've looked at, it's not like we're the first to kind of think about how we might segment the population, but and through our work, we've identified 12 published studies that, again, they apply data-driven segmentation methods to high-risk patient populations. And this is sometimes the healthcare and governmental sections. Our group's mission is to support our operations partner in primary care. So we wanted to move beyond just how to run the models, but to learn how we might best use these segmentation methods to inform clinical interventions. We want to actually do something with this information versus just publish on it. So yeah, we had conducted this literature review, and we did find some overlap, but the lessons are there's a variety of things going on. Choose data that will lead to meaningful interpretation. Missing or biased data can lead to incomplete misleading results. Very rarely, this is the most important part for our work, is that it's taken to the next step. What are you going to do with this? And there hasn't really been anything that's been like intervention-based work on if you've identified these segments, are there interventions that can be tailored to those groups?
Yep. Move on to the next slide.
Oh, there is. Okay. So a prescription for designing a data-driven population segmentation analysis. So you begin with a population. You have to ensure that you have adequate size of the patient population. You also there need to be some differences that actually can be identified from segmentation analysis. You can choose populations based on predicted risk, costs, multimorbidities. It depends on sort of the intended thing that you're trying to fix or you're focused on. In this situation, you define the focus of segmentation by identifying the outcomes of interest, range of domains of possible interventions. For us, it would be, then you begin to start to thinking about data inputs. So you might assess which data sources are accessible for the entire population that you're going to try to ultimately make subgroups from. Map those data inputs to the information needed to develop and tailor interventions, include limits, constraints, think about biases of available information, where your information is coming from, what might be incomplete versus complete when you're thinking about your results. And then there's the modeling approach. We have chosen a method called latent class analysis, where we choose either a patient or health condition, and it's a clustering approach. And that helps us develop a priori sort of statistical criteria for choosing the optimal number of classes or segments that can be extracted from actual veteran population data. And the next steps would be to validate groupings based on prospective health outcomes. So it's great that you find interesting looking segments of veterans who share similar comorbid conditions, but you want to make sure, these are sort of theoretical latent variables. You wanted them to be meaningful in terms of like prognosis for patients or prospective health outcomes. And then once you have these groups of veterans, you can kind of profile them and say, sort of, are there differences in age groups? Is one class older than another? Are there differences in inequities in disparities, differences in utilization, differences in modifiable health risks? And the idea there is you not only have these sort of classes or segments that you're dealing with that are veterans that have similar problems, but you're understanding who they are. So how to go about finding them, and then thinking specifically about how you would tailor or test an intervention for each group's or segment's profile.
Great, thanks, Josh. So in this project that we're going to tell you, go into detail about, we tried to follow those lessons learned and those steps that we identified and recommended when it comes to the topic of patients in primary care who are at high risk for poor outcomes and have complex healthcare needs. So I'm going to turn it over to Franya Hutchins.
Hi, can you hear me, Anne-Marie?
Yes.
Great. Okay, I'm Dr. Franya Hutchins. I'm based here at VA Pittsburgh, and I'm going to be talking through the segmentation models that we use specifically for patients in the VA. And these first 3 slides, I'm not going to spend too much time on because Josh did a good job of covering the context of our work. But this is just to say that our group focuses on supporting veterans that are at a high risk of hospitalization. These patients use a lot of health services and they often have multiple chronic conditions. So it becomes very challenging for healthcare teams to help these patients stay healthy and avoid the hospital. In the VA, as Josh mentioned, we have the ability to identify which patients on a primary care panel are at high risk for poor outcomes with CAN scores and other types of risk scores, and we can predict that at fairly high accuracy. But 2 patients can be high risk for very different reasons. And our examples here are you may have a patient who is an elderly man with heart failure, diabetes, and frailty that has the exact same CAN score or risk score as a young woman with substance use disorders, housing instability, and high blood pressure. And although these patients share a risk level and you may be able to predict that risk level very accurately, from the care team's perspective, it's very challenging to either to care or to design interventions for this really heterogeneous population. So primary care teams are responsible for lowering risk and improving outcomes for this wide variety of patients, especially in the high-risk subpopulation. So on one hand, you could provide comprehensive assessment for each individual patient. That's very time-consuming. Alternative interventions that have suggested one-size-fits-all programs for high-risk patients have not shown really that they significantly impact outcomes. And so this is where we come in, and we felt that this is a perfect situation for segmentation analysis to balance these needs for population and individualized approach. And now we can really jump into what our particular solution has been. So what we decided to do is to use VA data to discover data-driven groups among high-risk patients. So we apply specifically latent class analysis mostly to identify patterns of comorbidity within the high-risk population and use that to assign high-risk patients to common groups, and then we can develop group-specific care steps for these groups, and that is what Dr. Rosland is going to talk about next. So this supports proactive, efficient management of high-risk patients. No, you're good, we can go there, yeah. Thank you. Okay, so with our latent class models, this is what we primarily use to identify groups within our high-risk population. So the first task with using latent class models is to test a range for the number of classes or groups that you want to model. You use fit statistics balanced with clinical knowledge to choose a number of classes for the final model, and then that final model you pull these estimates from. So the type of estimates you get are how many people are in each group in the patient population, how likely each condition that you use in the modeling is to occur within each group. So for example, if diabetes is one of the conditions that you use in modeling, how likely is it that diabetes occurs in each of the groups that you have found. And then finally, you get an estimate for how well each patient matches with each group. So that's the probability of group membership per patient for each group. And for a patient, ideally you want to see a high probability of matching with one group over the others. And this is a really nice feature of latent class analysis in particular, because it gives you an idea of the confidence that the model has in this match of a patient with a group, as opposed to other models that directly categorize every patient in your population, and you don't know, really, you don't get an estimate for that level of fit that you get here. So that's nice. Okay, next slide, thanks. So let's talk about how we built our models. We're going to show results for 2018 and 2020 high-risk patients, and we applied latent class analysis to identify profiles, again, of chronic condition comorbidity. That's what we focused on. So the population was VA primary care patients with a care assessment needs score in the 90th percentile or above at any point in calendar year 2020, and then, 2018, and then we did it again in 2020. So basically, primary care patients with a high risk of 1-year hospitalization is our population. Input into the models, we used diagnoses of 26 chronic conditions. We chose these conditions to represent all major body systems and conditions that were important to veteran care, such as PTSD, to get the most complete patterns. And we focused on conditions that are managed in primary care to increase the chance that our results will be relevant to primary care interventions. Some definitions: each condition was defined as present if there was any ICD-10 code for that condition in the 2 years prior to cohort entry, and we tested 1 to 7 classes. So let's take a look at some of the results that we saw. This shows a breakdown of the classes that we found in 2018 and 2020, and we had nearly 1 million patients in the high-risk population for each of those years. We chose a 5-class model as a good balance of model fit and clinical utility, and we assigned patients to a group using that model-based predicted probability of group membership that I mentioned before. For these particular results, we used a cutoff of 50%. So we put each patient in the group that they matched best with based on predicted probability, but if they did not match with any group at 50%, or higher, then we put them in this unassigned categorized that is shown at the bottom. So that's what that means. So over 90% of patients were categorized using these definitions, but that's what that is. So when you do latent class analysis, the investigator or you basically interpret the classes that it shows you. So these labels are something that we put on to each class based on the prevalent conditions among patients that we assign to the class. So in the, don't go there yet, Anne-Marie, but in the next slide, I'll show in a little bit more detail how the conditions map onto these classes, but just so you can interpret this slide, we had a class that we labeled low diagnosis, and it has patients in this class have a low prevalence of most conditions. A cardiometabolic group where there were very high prevalence among these patients of coronary artery disease, heart failure, and arrhythmia. A mental health group that had a high prevalence of PTSD, depression, and anxiety. And then a substance use disorders group that also had high prevalence of these mental health disorders, but in addition had high prevalence of alcohol, substance, or nicotine use disorders. And then finally, we had about up to 10% of patients were assigned to a group we called multi-system, where these patients assigned to these groups had diagnoses of chronic conditions across multiple physiologic systems. And last thing before we leave this slide, notice that the prevalence of each group, so how large proportionally each group was very similar 2018 to 2020. So in that respect, the models were very stable. Okay, let's see the diagnoses a little bit in more detail. And this is not to be interpreted, line by line, but we wanted to really highlight how the conditions map onto the different groups. So here we have prevalence of each condition for 2018, which is the blue bars, and 2020, which is the black outline around the bars. Your first column here on the left is overall, and then the following columns are divided by group. So we have substance, mental health, cardiometabolic, low diagnosis, and then multi-system. And so, for example, you can see the illustration of what I was explaining before, that the first group here, the substance use group has a high prevalence. These top three are alcohol, substance, and nicotine use disorders. So you can track, you know, left to right across the groups. They have very high prevalence comparatively. And then that next section down is the mental health diagnoses. So PTSD, depression, anxiety, bipolar disorder. If you go over one column and you see the diagnosis profile for the mental health group, very low substance use diagnoses, but high comparatively mental health. And then one more column over, this is the cardiometabolic group, and you see very low prevalence of substance use disorders, mental health diagnoses, but then relatively high coronary artery disease. That's the next arrhythmia, heart failure. So that next section there is showing cardiovascular. And again, really the point that we want to put across showing this level of detail is that these models look for patterns in comorbidity profile as opposed to assigning patients based on a checklist of diagnoses. So there is a level of nuance, and not every patient in a particular group has to have one specific diagnosis or another. Okay, thanks, Anne-Marie. Something we wanted to highlight is individual change in group over time. This is something that is really very rarely looked at in the literature, so we wanted to demonstrate how important it is to check on individual change when using subgroups to inform clinical care. So we tracked the individual status between 2018 and 2020 and found that people moved in and out of eligibility for high-risk patient status and were assigned to different groups. This table here illustrates patient change from latent class assignment in 2018 to their status in 2020. So the blue squares, the diagonal there, represents agreement among classes for patients who were observed in both years. So for example, among people who were observed in both years, those who were assigned to the substance use disorder group in 2018, 64% of them were assigned to the same group in 2020. Taking one step back though, only 59% of the high-risk patients in 2018 were still high risk in 2020. This is not shown on the slide, but 25% had an improved CAN score and 14 had passed prior to 2020. So among patients, again, who were high risk in 2018 and 2020, those assigned to the cardiometabolic group were the most likely to be reassigned to the same group in 2020. So as we saw, you have similar numbers of people that are considered high risk in each year, but on an individual level, there is a lot of change. So that has big implications for the type of, both the type of intervention that you might design around this and the type of outcomes that you might want to track if you're evaluating an intervention. A focus of our group is to assess the equity of models that we use to inform clinical care. So machine learning algorithms, including latent class analysis, basically they take in old data to learn and make predictions or inferences about new data. On a surface level, this is value-free and not concerned with causation because it's totally data-driven. But as health service researchers know, the data we see are a result of a series of events, each of which is informed by social structures. Socially marginalized groups are more likely to be exposed to health risk factors and more likely to face obstacles in receiving care. So our data, using health services data, they really reflect, or you could even see it as being filtered in a way through the systematic differences between social groups, whether that's differences in exposure, patient service seeking, healthcare access, or even providers' decisions such as referrals and diagnoses. So even models that, or especially models that are completely data-driven, they're very vulnerable to basically recycling the systematic issues that are in the data generating process. So ways that this translates into prediction models specifically includes that an algorithm can unintentionally punish patients from underserved groups because their health is already compromised by social obstacles. So for example, you may have heard the debate around EGFR equations, which are used to estimate kidney functions. One of these in particular increases the kidney function score if a patient is identified to be Black. So the result is that Black patients are estimated to have better kidney function compared to white patients with the same creatinine level. So they are systematically less likely to be referred to specialist care or listing for transplantation, even at the same functioning level biologically. Another way that this can manifest is algorithms will also perform better for large subgroups in your data compared to small subgroups. So they can perform poorly for small groups that are different in clinically relevant ways from the main population. And one thing that we also wanted to highlight here is that most methods for assessing equity focus on evaluating algorithms that predict an observed outcome. So the supervised models that Josh was referring to earlier, most of our equity work in the machine learning space is about differences in prediction. So what our group's been doing is working on ways to assess and address equity in latent class models. So as I implied, we haven't seen any published segmentation studies that directly assess equity, but we believe steps like what we show here on the slide should become standard for segmentation analyses in the future. So what are some things you can check with your models? Are your models performing well for subgroups in your population? And so in this context, subgroups or groups is referring to like social categories like race or ethnicity or gender. So checking performance, again, this is a little more tricky because we don't have an outcome, so we don't have a true outcome or a benchmark that we can compare to. These class assignment is latent and by definition unobservable. But there are a few things you can do. You can check the predictive probability of group membership across your subgroups to see if models are performing well across groups. You can compare the actual profiles of the conditions that you put into the groups to see if group membership is qualitatively means the same thing for different groups. So for men or women or for people from different racial ethnic groups. And then it's really important, again, to understand the missing data structure of your data. So understand if there are conditions that you're working with that are known to be underdiagnosed in certain subpopulations, access issues, subpopulations that may be represented in your data, but that have care that is missed or diagnoses that are not included because they receive care elsewhere as well. Then on the other side, what are some options for working with these data to improve the equity of your models? Something we're working on right now is adding covariates directly into the latent class model themselves and seeing what effect that has on equity and performance of the models. If you suspect qualitatively different subgroups, you can stratify models. There are methods to do that very directly in latent class analysis. And then for missing data, it's always very tricky working with around missing data, and is what makes being an epidemiologist so fun. But some things to work to address missing data are finding validation samples within your population with more complete data, integrating different data sources, and potentially imputation. And this is ongoing work in our group, so please reach out if you have follow-up questions or are interested in similar approaches. And now that we've gone over the models, we'd like to spend some time on potential clinical applications. So I will hand back over to Dr. Rosland.
Great, thanks. So in this last section of the presentation, we're going to talk about the steps we've taken to develop applications based on these models, and one particular application, the first version of which is already available to VA primary care teams. So basically, as we've been mentioning throughout this presentation, if you go to PubMed, it's easy to find publications that say, look at these subgroups we found, isn't this interesting? And they all seem to stop there. So we really want to take the next step. We think, from our rigorous modeling techniques that we've found segments of this high-risk population that cover most of the high-risk patients, that seem very clinically distinct in terms of what conditions they have, that we're making sure are equitable. So now that we have these really reliable models, how can we use these to inform patient care in the VA? So the next steps that we've taken are first to look at how outcome patterns are different between different groups. And then also look at utilization of healthcare services by each group, and combine all this information, including diagnosis patterns, to try to get a sense of what unique care needs or gaps in care each group has. These next graphs show descriptive data for each of the 5 high-risk patient groups that we identified in 2018. Each group in these graphs has a different color. This multi-body system group is in dark red. The cardiometabolic group is in this salmon color. Mental health group is gray. Substance use disorders are blue. And then people with relatively low diagnoses are in yellow. And then there are 3 outcomes shown on this slide. On the left is the percent of each group who died in the year following group assignment. In the middle is the percent that had at least 1 acute hospitalization. And on the right is the percent that had a rehospitalization within 30 days of hospital discharge. So looking at outcomes patterns in these ways serves 2 purposes, really. One of them is, do these latent classes that we found seem clinically meaningful? And our statisticians describe this as construct validity. Again, just kind of giving us a sense of, is it helpful and meaningful to separate patients in these ways? And the fact that we see such different rates among people who started out, remember, all being at the same predicted risk of hospitalization, gives us a clue this is very meaningful. And to further, follow this idea of construct validity, we do run multivariable models that adjust rates of outcomes for things like age, sex, so that we are sure that we're not just seeing confounding patterns. The other, again, reason that we can use these data as clinicians or program leaders or people who are designing interventions is to give us a sense of what outcomes and what care to target differently for each group. So one thing I'll show you, I'll focus in on these groups that Dr. Hutchins highlighted, the mental health group in gray and the substance use disorder group in blue, who, to many of us might seem like, oh, that sounds pretty similar. One of the things you'll notice here is that our gray group, the mental health group, has a much lower risk of hospitalization over 1 year than this substance use group. And again, the blue substance use group has more than double the risk of a 30-day readmission. This graph is similar in structure, but it shows characteristics of the patients in each group. So this will give you this gives us the mean age of the patients in each group, the percent who are men in each group, and the percent who are married. And so using this kind of data can give you a sense of sort of the typical or average person in each group. So for example, again, kind of focusing in on this gray versus blue comparison, the patients in the mental health group in gray are on average 10 years older than those in the substance use group. Both groups have a higher percentage of women than some of these other groups like cardiometabolic and the multi-system. But then when we come over to percent married, double of the people in the mental health group, twice as many, are married as the substance use group. So again, this, these groups represent a range of people, obviously, but if you were going to paint sort of a picture of the typical person, you might have in the gray group a middle-aged person who's more likely to be a woman than the other patients in the other groups, who is, many of whom are married, for example. This slide shows some indicators of socioeconomic status. Now, this slide comes with a huge caveat that these data are only come from the electronic health record. So as people who study social determinants of health know very well, these data that we can get from the health record on these factors is notoriously incomplete. And, again, a good example of we can only use the data that we have. But still, our philosophy, knowing that, is to use whatever data we have to help inform, how we might help people. So here we have some indicators that people have underemployment, both from ICD-10 codes and also from services they've used in the VA. And this is a really particularly common problem for people in the substance use group. But then if looking at housing instability, also common in the blue group, but very high in the multi-system group also. We have some indicators from VA data of whether people have low personal income, for example, being copay exempt, which is particularly common across all the groups. And then the one on the right matches the location the patient lives with census tract information about their neighborhood. So again, if depending on what group you're interested in, you can look across these and find pretty subtle differences in patterns. While the neighborhoods all look pretty similar across groups, the personal indicators of personal income we have for patients are different. Again, giving you a sense of both where you might reach out to help these patients, in what setting, and also what type of needs they might have in the healthcare system. Great. And this is the last slide I have for you on descriptive data. This slide shows, it's a little bit different structure. It shows the number of encounters in different places in the VA that patients had in each group. And so on average over 1 year. So for example, the first set of bars is in-person visits to primary care over 1 year. And you would interpret this as, the gray group, mental health group, had an average of 5 visits per year. The next set is phone encounters in primary care. And this is people who entered the highest cohort in 2018 and looking forward for 1 year. So this covers 2019, so before the pandemic. Phone visits. This is outpatient subspecialist visits, again, cardiology, oncology, et cetera. ED or urgent care visits per year, and then encounters in mental health, either individual or group setting. This again, I think I can already, and I bet a lot of you are thinking of different ways you could use this data. One of the things that this can inform is kind of where to find people. So if we had, let's say, a phone intervention, we may have trouble reaching people in the blue group, the substance use group, but we may be able to find them when they come to the emergency room. We may be able to deliver our intervention that way, or when they come for mental health care. So one particular tool that we have used to inform with this data is a tool that exists within the Patient Care Assessment System, or PCAS. The PCAS is a tool that is available for all PACT teams or across the VA. And it draws from information that is coming from VA administrative systems, VA health records, to allow PACT teams to manage their panels in sort of a proactive panel approach way. So when we thought about how our information could apply to the PCAS tool, we knew that we had these subgroups. We knew that our groups had different outcome and utilization patterns, as I just showed. We showed those patterns to some expert panels across the VA who represented people who led mental health care, geriatrics care. We tried to find a wide range of folks who could give us reflections on how we would use these patterns. And then we got to work programming some features into PCAS with the team in CSDE that is in charge of this tool, which was also sponsored by the Spark Seed Spread program. And then we took this tool that we developed, which I'm about to show you, and took it through 2 rounds of user testing with VA primary care providers and nurse care managers, and improved the layout and the functionality of the tool with each round. So one of the last pieces of information that I haven't showed you yet that we used to decide what to put into our tool is that we looked at each group's use of VA programs. And in the first version of the tool that I'm going to show you screenshots from, we were using a slightly older set of groups that I've just labeled group 1, 2, 3, 4 so that we don't get confused with the earlier data that we were looking at. And we looked at what percentage of each group used particular VA programs in each year. So for example, telehealth, home-based primary care. And we compared that program use to other things we knew about their medical conditions, their outcomes, to look for places where there might be gaps in what each group was getting. And 2 particularly, I think, compelling examples of that. One is that for our group 2, this was a group that happened to have a very high rate of hospitalization and rehospitalization, but a relatively low use of home-based primary care, which kind of stood out to us. And then we also knew that our group 5 had a particularly high rate of death, of mortality, but a lower than expected use of outpatient palliative care. So those are 2 we call care gaps that we focused on in our tool. So this shows you a screenshot of what you will see if you log into the PCAS system. And there's a link on the bottom if you are a PACT team member or someone who works in outpatient primary care, or sorry, outpatient VA care. You can click on that link and see a grid just like this with your own patients. This is the latest version of PCAS, PCAS 5.0. And we worked with the PCAS CDSE team to add the ability to show and sort HiCAN patients by their clinical subgroup as we identified by our latent class analysis. So this is a screenshot of what a PACT team member will see when they access PCAS. Patients on the PACT panel will be listed on the bottom and can be sorted by these different filters on the top. The new filter that's highlighted here is the CAN by comorbidity group. So if you click on a certain HiCAN score patient's comorbidity group, which is also highlighted down here, you'll see a page for that patient with information about that individual's pattern of diagnoses, their subgroup, in this case, this patient is in the cardiometabolic group, and information about that group. For example, we noted patients in this group who also have kidney disease or mental health conditions are at highest risk for hospitalization. That's something that we saw as a pattern in our data. And then there are care steps based on these care gaps that we identified that are suggested to consider for anyone in this group. On the right side, we indicate whether the patient has received this care step already, so that would be a yes, whether it doesn't apply to them, so this patient must not have chronic kidney disease at that stage, or if it does apply to them and they haven't had it yet, PCAS allows the user to add a task to the patient's care plan. At the bottom of the page, there's more general information about the patient's group, which can give clinicians a sense of those health use and outcome patterns that are common for people in this group. For example, patients in this green cardiometabolic group tended to have high rates of visits to subspecialists and low rates of referral to palliative care. And then on the right of the bottom of this page is a graph that shows how common each diagnosis is for the group in general. So we're particularly excited about this new function in PCAS, and we are making plans to develop and test it further for PACT teams to use in panel management or possibly even at the point of care. But on this last slide, we list some other possible uses for the subgroups information that we've shown you today. So, you know, definitely we've talked about tailoring bundled interventions to each group's common diagnoses or needs. We're also envisioning that PACT teams could monitor patients for conditions that are the most common reasons for hospital admission in each group. And like I mentioned earlier, if we do have a program that's trying to reach patients in a certain group, we can use this information to find where they are, whether it's they commonly come to the emergency room or they access care over the phone. There are efforts in the VA to coordinate among the care coordinators, and for complex patients, assign a primary case manager or care coordinator. And this data, we think, can allow us to figure out, where is a patient's care coordination home? Is it in a certain subspecialty clinic? Is it in primary care? Is it in a housing services program? Definitely this, at a facility level, this segmentation or subgroups information could allow a facility to track quality metrics or outcomes by group. And this can really help, I think, could help facilities really hone in on groups that are kind of representing more difficulty reaching the quality metrics, and that facilities could really target and hone in on. And then last but not least, programs or program offices that are looking for people that could use their program could really hone in on those groups that seem to have a need for their service but aren't getting it as much, like home-based primary care or palliative care, as I mentioned, as two examples. So I'll end there. Here we have information on how to reach the three of us. More information on the PCAST tool in general that I showed you. Information about our sponsors, the VA Office of Primary Care Analytic Team. And last but not least, if anyone is interested in the work of our High Risk Investigator Network, we have a website for that.
Thank you so much. We have just a couple minutes left, and we have a couple questions lined up. And one of those questions is, aren't care teams performing individualized assessments in the usual course of care planning?
That is a good question. I guess, you know, the devil's in the details in terms of what the person asking the question means by some of these terms, but definitely a primary care provider, people on the primary care team, pharmacists, social workers are assessing people's needs, but it's often through a particular lens of the types of things they treat, or certain conditions that are sort of high priority at the moment. And so what we're hoping is that, you know, this information about all of the conditions and the experiences that a patient in a group is having gives more of a holistic view of, you know, all the different needs that they might have, and really kind of jumpstarts you in thinking about what, you know, a full care plan would be that would be tailored to them. Hopefully that helps.
Okay, and somebody said very interesting and robust overlap with 2020 data. And then we have a question. There was no coding documentation initiative between these time points. Noted one slide with more in group 2020 versus 2018, but no decrease, for example, in tobacco.
I'm wondering if Dr. Hutchins has any thoughts on this. I'm thinking what this questioner might be referring to is, you know, did we look at just the prevalence of each condition in 2018 and 2020 to see if a certain diagnosis, the level of it changed? Which we did not show that today, but we did overall for our whole group.
Yeah, we did not see much change at all overall in diagnoses. Something that in that particular graph that I think they're referring to that can be tricky is that because we have so many patients, a small change in the size of the group itself can make it look like the diagnosis changes or doesn't change in a way you don't expect, if that makes sense. So if one year a group is 5% and then the next year some patients are moved to a different group, the individual prevalence of that condition is still within the one group, so it can shift a little, and it can be difficult to interpret on the fly like that. But yeah, we did check overall year to year, and you know, we kept our definitions the same in the time period where we switched from ICD-9 to ICD-10. That was previous to these results that we showed. So there shouldn't be too much definition change or misclassifications of that type.
Thank you. And we have time for one last question. Thank you for sharing this fascinating work. It seems like PCPs are trained to use uh, mechan m- mechanistic reasoning to mentally sort patients into non-latent subgroups based on their diagnoses. For example, patients with alcohol use disorder would be in the subgroup that is likely to have cirrhosis. Do you think this method of grouping patients is inferior to your method, maybe because it's more vulnerable to bias?
That is a great question. And one of the things that we're really thinking about is how to help clinicians interpret, how do you interpret the fact that somebody has a high likelihood of having a condition or a series of conditions when it's not black and white. So it's not how we're used to thinking about things. I don't know if I would say it's inferior because of bias, but what kind of, to me, the biggest limitation of kind of dividing people into yes or no groups and then further dividing those groups is that you start to get smaller and smaller and smaller people who are eligible for your program. So if you have a care or program that's for people who have only for people with alcohol use disorder and liver disease and depression, that's a very small, ends up being a very small segment of your population that program is for. And so we're trying to avoid that dividing people into too many groups by trying to find a kind of a parsimonious number of groups that people can wrap their heads around, in 5, 6 groups, as opposed to really separating people in such tiny ways. So that's where I think this method can really be helpful.
I want to thank you all for preparing and taking the time to present at this cyber seminar. Do you have any closing remarks?
Just that I'll also just say we really appreciate all this interest, these great questions, and we're hoping that to reach people with lots of different backgrounds and perspectives. So please do reach out if you have any questions.
And for the audience, thank you everyone for joining us for today's HSR&D Cyber Seminar. When I close the meeting, you'll be prompted with a survey form. Please take a few moments to fill that out. We really do count and appreciate your feedback. Thank you everyone. Have a great day and stay safe.